Hello, and welcome back to Wired for Change, where we look at the people, human stories, ideas, and technology that are driving change in our world. I'm your host, Amy Yee. Today, I have a very special treat for my audience, and it is a very unique kind of experience that I think I'm bringing today. So, for over 6 or 7 years now, I've been a board member at Kemptville District Hospital, and it's really been a pleasure to serve the community in a very small way and to watch an amazing senior leadership team really just operate and meet challenges and just really excel at serving the community around us. And so I'm so pleased to have with us today the senior leadership team from Kemptville District Hospital. Now, just before I mention who they are, the Kemptville District Hospital is a 40-bed acute hospital that provides 24-hour emergency care, inpatient and outpatient services, advanced treatments all over the place. And I'll let the team get more into that and how they serve the community. And now I'll introduce them and mention their names. And I have with us today Katie Hogue, who is the VP of Clinical and Nursing Services as well as the Chief Nursing Executive. Welcome, Katie.
Thank you. It's great to be here.
Thank you. And I've got Brittany Rivard, who is the CFO and also VP Operations at Kemptville District Hospital. Welcome.
Thank you.
And I've got Frank Vassallo, who is the CEO of Kemptville District Hospital for a number of years now. Welcome, Frank.
Good. Thank you for having us.
Excellent. There are so many reasons why I'm excited to have you all here today. One of them is that we often, or it's easier to hear from big hospitals in the news, and we rarely get a chance to get to know hospitals that are in the community, serving geographically dispersed communities who are out there doing such amazing work. And so I'm happy to get a chance to really highlight that today. And then also, just I admire this team so much, and I have had the pleasure of watching you for years. And I just really wanted to have the chance to bring that conversation to light and to see how you work together and to share that with others as well. So thank you for being here. Let's start off just by having each of you tell our audience a little bit about yourselves. And so, Katie, maybe I'll start with you.
Great. So, I'm a nurse practitioner by background. Started off my career as a nurse in critical care in Sudbury, and was really excited about the opportunities for nurses and nursing leadership. And so, I became a nurse practitioner. I moved to Parry Sound and worked there for 12 years as a frontline NP in primary care, also in the hospital as a director through the pandemic as a pandemic lead, and then as their chief nursing officer. And I had the opportunity to move to the area, a transfer with my family, and I was privileged to join the Kemptville team last year, and just really excited to continue to grow with this team as their CNE.
Amazing.
Yeah.
Thank you. Brittany.
Thank you. Yes, we are absolutely privileged to have Katie on our team, and she's been such a great addition. I came to Kemptville about 4 years ago during the pandemic as the CFO and VP Operations. And prior to that, I was at Sick Kids for 6 years. And at Sick Kids, I was actually on the clinical team. So I have a bit of a unique background where educationally, I came from a health sciences undergraduate background, and then I got a degree in business, became an accountant through PricewaterhouseCoopers, moved on to Bell Canada, where I managed revenue for a number of years, which definitely taught me that connection to the mission is so important. And for me, I just didn't feel that connection to telecom, and it really forced me to make the reflective decision that I need to move back towards healthcare. That is where my heart lies. That's when I pursued Sick Kids primarily, but healthcare in general, and was fortunate to land in the Department of Dentistry there, where I managed it both clinically and from the business side, and then became the director of clinical funding strategy there, which was really a connector role. And I was both a funding expert, but worked very closely with the health records team, worked with physicians there, educating them on how the decisions they make on the front line and the way they code really affects the finances and affects everything that we do in the operations. And I think that it's been such a privilege to come to a smaller organization like Kemptville and a community where you can be so connected, because I've been really fortunate in my career to have very diverse roles, and I get to continue in that in my role today.
so helpful for moving things forward when you've got that diverse background. Amazing. Great. Frank.
Well, as you mentioned, my name is Frank Vassallo. I'm the proud CEO of the Kemptville District Hospital, and even more proud to work with these two fantastic executives, Brittany and Katie. I came into my role through a rather circuitous route. I have a BSc in kinesiology that really built on my love of science and sport and health. And I wanted to combine my health interest with business. So I pursued a master's in health admin. I worked with that master's degree in many spaces in the public and private sector. Started off at Hamilton Health Sciences, seconded to the ministry for a while, did some work in the private sector with a European-based diagnostic imaging company. I wanted to get a bit more tools in my toolbox other than what I was taught during my master's in health admin. So I pursued a master's in public relations at McMaster in Syracuse. It's a joint program, a master's in communication management. And I believe it really built up my toolbox so I can build effective relationships and communicate with various interested parties. I had various VP roles throughout the sector, health sector. I won't mention them all, but the most important one is the one I'm currently in. I believe it's the most exciting job I've ever had. Surrounded by great people, and I have to give a nod and pay homage to the great board we have as well. Without a great board and a great community, the senior leadership team and all of the management team would not be supported well. So I'm happy to be here and look forward to the conversation.
Amazing. Thanks so much. And it's been, again, such an honor to be on the board. I will take off my board hat now and just be a podcaster, but obviously a podcaster with a bias. And I don't know how often it happens that a board member interviews a senior team on a podcast. I'm going to say it's probably one of the first.
Yeah.
And you've all listened to the podcast as well
Yes,
before,
yeah.
so you kind of know what it's about, and that we're really just trying to help, change leaders and change makers to drive change, wherever they are. So really appreciate your support for that, and thanks for listening to the podcast too. So let's learn a little bit more about Kemptville Hospital. I do have listeners from all over the world, as well as some that are very local. I mean, Kemptville is located about 40 minutes south of Ottawa, Canada's capital. It's a growing region, I think, as a part of some of the dynamics that you're working with. And so maybe you could just tell us a little bit more about Kemptville's history and staff. You may have staff listening to the podcast as well at some point also.
Absolutely.
Yeah.
Want me to kick it off?
Yeah.
Well, you'll notice that you and your listeners and viewers, we tag team well as a senior leadership team. So maybe I'll kick it off. So we started in 1960, June of 1960, and although we're framed as a small rural hospital, as you correctly pointed out, Amy, we're 40-minute drive from downtown Ottawa. So we really are a bedroom community of Ottawa, and we have a growing population that's just exploding. I learned last week that we're not only the second fastest growing municipality in all of Eastern Ontario, we're the second fastest growing municipality in all of Ontario after the York region. So you can well imagine that puts a lot of pressure on the demand for health services and providing of health services, more importantly. And, when you look at the folks who are moving into our community, it isn't just an older age group. It's pretty well everybody from Gen Alpha all the way back to the greatest generations, folks that are in their 90s and even older. So we have to make sure that we have a good handle on everybody that is in our community that we serve. A couple more points before I pass the proverbial mic on to my colleagues. We have such an amazing team, not just the senior leadership team that I'm privileged to work with, but I've really appreciated over the last couple of years how not only how strong and how resilient our team members are, but how they're stepping up to the leadership mantle, especially our nursing colleagues. It's a tough time to be in the nursing profession, but our nurses get it that if they wanted to be part of change, what better position or perch to be on than in a leadership position to actually, architect and steward that change. So those are some of the, key attributes that I find really comforting as a CEO. I'm incredibly well supported. I lead a great organization, but I'm not leading by myself. I've got great support, and I'll pass it on to Brittany and Katie to round out some more context.
Thanks.
Yeah, I think one of the most exciting part about joining Kemptville last year was being able to continue the work that I had done in a rural community. It's so unique in that you really get a sense of what the community needs are because you have the ability to connect. And I know we're going to talk a little bit more about what makes Kemptville really unique and the partnerships, but it really is about those partnerships. Our staff, our leaders, to Frank's point, are so strong, not just in KDH, but in the community. Many of our managers are part of community committees. They attend community events. They have the connections that oftentimes we know before anything is released, before any environmental scan happens, exactly what's happening in the community and how we can pivot to meet the needs of those community members. Um, Being a leader in a small hospital is I'm so glad that we're talking about it because I think it's often undervalued
Mhm.
and that we are doing so much. We are involved at every level. We don't have directors that are doing work for us. We have managers that are directly involved with really cool, amazing projects that really change the face of the healthcare that we're able to deliver, and that's exciting.
Nice.
Yeah.
What's an example of that?
Well, I think if you look at just our surgical program, so we have surgical partnerships with the Ottawa Hospital, which is a large tertiary hospital, and we're really unique in how we deliver that service. The managers are directly at the table. Just as early as this morning, we talked about how we're building capacity for the future for Kemptville, for our growing community, and having the managers directly involved and the team leads directly involved with looking at the operating room structure, looking at what cases make the most sense for the community and how we can do that. Our physician leaders are incredible and they're at the table as well. They're very involved with all the decisions that are being made, which is I think very different from a large hospital, at least in my experience. We don't have that connected team with all of our senior leaders, including physicians and managers and frontline staff.
Mhm.
Wow. Beautiful.
Yeah.
That's exciting. We'll pick up on that again.
Yeah. So, and I could build on that a little bit as well, coming from, so from my journey from in my career went from very, very large organizations. PwC is a multinational organization to Bell, it's national. SickKids is very well known, very well connected on University Avenue in Toronto to Kemptville. And I can certainly see how that progresses. Like, definitely our managers are involved at a level that you would only really get at the director level in a larger place. And you can see that even on, as you mentioned, the meeting today, it's our manager who's leading a call with directors and executive directors of the Ottawa Hospital, because you have to get to that level at the Ottawa Hospital before you're leading partnership opportunities. But in a smaller organization, you get to lead that as soon as you're in that manager level. And oftentimes, the managers who are progressing at our organization are first time managers.
Hmm.
So they're younger, they're people who've just come out of MHAs, and we're really a talent pool for the region. And what's nice is we've actually created a culture where they stay. I
Yeah.
think prior to that, often in small hospitals, you get managers who are coming up who are less experienced because small hospitals have to pay slightly less. Our budgeting is a little bit smaller and less robust than urban centers, but uh, you get opportunities earlier, you get this exposure earlier. And so it's attractive to people who are up and comers. But then they do get opportunities in larger centers and they move on in order to progress their career. That hasn't really been happening for us because of the nature of our team, because we've invested so much in the culture of our team. We trust our managers. We all have each other's backs, both from a workload perspective and really investing in the processes, but also in a psychological safety and mental health perspective, which is something I'm very passionate about. So we've spent a lot of time on that, and I think it is trickling down. Frontline staff are passionate about our organization as well. But there is a phenomena, especially in the Ottawa Valley, where you've got lots of rural hospitals sort of in a horseshoe around the urban center, and you get people who are working either casual or part-time jobs at multiple of the different hospitals. So, clinical staff especially tend to bring cultures from other organizations in, which can be good and bad, it depends.
Mhm.
But it also brings in new ideas, and there's that constant refresh of ideas. So there's a lot of positives there. I think the other thing that is important to understand about Kemptville as a small hospital is the funding model. It affects so much. Funding in Ontario is extremely complex. You have to remember that Ontario has by far the largest population in Canada, and it is healthcare is the largest budget um, for the provincial government, so it gets a lot of scrutiny. And large hospitals have these very complex formulas, but small hospitals are funded from a base perspective, which means we get a lump sum of money. It gets a percentage increase year on year, and that's it. There's really no adjustment for these demographic changes or changes in the underlying acuity of the population. So when you or Frank are talking about the growth of our community, that is something we have to, as a senior team, really advocate for in order to adjust our funding. It's not something that gets reflected automatically. So, yeah, I think those are some of my
Yeah.
key
Now,
points.
Yeah.
Brittany being our CFO, she she could be very eloquent with the financial. I'll leave all the financial pieces to Brittany and the clinical realm to Katie. But when people look to me for what really excites me about Kemptville in terms of what I look forward to going in, I mentioned the leadership
Mhm.
and the resiliency of
Mhm.
our team. I truly believe our strongest asset would be our people, without a doubt. I mean, without them, we wouldn't have been able to do half of the initiatives that we've been able to do over the last 3 to 4 years. And if you look at what an organization relies upon through its people, you need to invest in that construct. You just can't say people are a strong asset without investing in our folks, whether it be higher education, it could be courses, it could be certification, what have you. They know that we are concerned about their growth path, and we get a good sense of that through the engagement, which is another really thing we're proud of. We're really proud of how we engage our staff and how we communicate transparently, openly with them. And you could look back to the culture that we have, and that's all of those attributes define our culture. And we believe our staff, if you were to ask any of our staff, probably more so in the last few years than in the past, they would say they have a very safe space within which to work. They have no problem bringing issues to myself, Brittany, or Katie, or anybody else on our management team. They're heard, and they know they're heard. And I think a lot of the times you get the brainstorm ideas from the staff at all levels. Doesn't matter what level they're at. They feel and they believe their voice is heard. They matter, and we acknowledge that every day.
Mhm.
I think many of us believe that that staff experience for a lot of organizations like this translates directly to the patient
Yeah.
Yes.
experience. We at the board have the pleasure of hearing a lot of patient stories, come up from you. Maybe we could. Do you have any examples of patient stories that we could share just to help people understand what the experience is like at Kemptville versus maybe other or larger hospitals that they've been at? What defines Kemptville that way, just in terms of like how does it feel for a patient?
Well, I've got a quick one I'll just get on the table, and it's something I learned many years ago when I was interviewing for the job. We started a total joint replacement program, and our nutrition services had everything organized for the meals. Our first patient was a vegan patient, and our menu wasn't appropriate for that patient. Our food services manager took upon herself to go to the grocery store and, with her own money, buy a collection of food items that would be suitable for a vegan diet. And that was just so amazing. And that was the first week of our new total joint replacement program. We were just crushing it in the ORs and in the post-op and the pre-op areas. But that bedside care, taking it an extra level to really deliver what we now realize and acknowledge as patient-centered care,
Mhm.
was really born out of the actual work of our very own people. I was super proud to learn that.
So nice. Wow.
Yeah.
Can
Yeah, go
Yeah.
ahead.
Do you mind if I jump in? So I'll speak first to my personal experience because
Mhm.
I have to be in the emergency room a little too often with my young kids. I have a 5 and an 8-year-old who are semi-medically complex. And every time, one, being a small hospital, the wait times in our ED, even when they are long, are never as long as what you would experience in an urban center. So that in and of itself is already going to be a better patient experience. Consistently, when I say, oh, when I was first joining Kemptville, I would say, oh, I'm just starting out. I'm the CFO of Kemptville District Hospital. They're known in the community for their fast turnaround time for, like, if I need stitches, if I need a cast, go to Kemptville. They're gonna get you in and out so fast. They're gonna give you great care. They're gonna be so compassionate. And the level of um, thoroughness, I guess, is just astounding. My daughter had strep throat, what I thought was strep throat for too long, and we were trying to deal with it. And I ended up bringing her in to see a physician at the ED who was looking at her and was just making her giggle and was so kind. And we have CHEO in Ottawa. We're so fortunate to have a children's hospital here, but I find that the care that is given to my children when I bring them into Kemptville is is so personal, and there is so much compassion. Whether you are 5 or 95, like, you are going to get amazing care when you walk in at Kemptville. And then the other thing I want to call out, and it's not a direct patient story, but I think it speaks to the patient voice at Kemptville, which is our PFAC committee. So our patient and family advocacy. And we have these two just rock star individuals on PFAC named Ron and Sue. And every time I hear them share a story, it's new and interesting, and they are the most fascinating individuals. But that came from their experience as an inpatient. Ron was an inpatient with us. He stayed with us for many weeks. He interacted with so many nurses and so many physicians and got care, within diagnostics, within the lab, with, every element of our organization that you could name. And from that, because of his background in the various organizations that he's been a part of through his life, he really felt like giving back. And I think more than anything, that shows you that, when people come here at their most vulnerable, their worst point in their life, and then they come out of that feeling passionate enough to join a committee and wanting to give back, I think that's the type of organization you want to be a part of.
That says a lot.
Yeah.
Absolutely.
Well, and I have another story just from a patient-centered perspective, but just on that, we did have a patient who put in a complaint, and we welcome that. We have a patient relations nurse who is amazing and really takes the time to have that neutral approach around if there's a complaint or a compliment that comes in, really trying to understand where that's coming from. And so we did have a concern that came in around a requisition that was missed in translation, and it was due to a process. And if the patient hadn't come forward and the patient relations nurse hadn't followed up, we wouldn't know that there was a break in the system that needed to be fixed. And so we were able to change the process for these requisitions to ensure there was a feedback loop, so something didn't get missed. And the patient ended up joining our patient and family advisors. They came to the board, they presented their story, and we welcome that. We want to hear patient stories so that we can do better. um, Quality of care is um, such a huge part of providing care, and it's not something that we just do. We just went through our accreditation cycle, and I'm so thrilled we achieved 99%. Frank likes to say 100; he likes to round it up. But it's an opportunity to improve care. So everything that you learn every time you get to hear that feedback, that's an opportunity to continue to do better and to continue to learn where there's a break in the system. There's also an opportunity for us to look at how our system is changing.
Yeah.
So I joined last year. Where I joined Kemptville is very different from what Kemptville looked like 10 years ago. The patients are a lot more complex. We're seeing a lot more inpatient care that is not um, uh, alternate level of care. So they're not waiting for a retirement home or long term care home. People are sick. They need IV antibiotics. They need inpatient care. We're less likely to transfer patients to the tertiary center, number one, because they don't have room, but we're also a hospital. And we're learning how we can continue to improve that care and keep that care closer to home. Brittany mentioned the managers that we've kept. We've also recruited some really amazing team members. Um, I was on call one of the weeks that I was working, and I was just doing rounds. I happened to run into the team lead and the physician that was on the hospitalist unit, and they said there was a patient that was in the emergency department who had a device that they weren't quite comfortable with. It wasn't something that we normally would have at Kemptville. Uh, Being a nurse practitioner and working in a large tertiary hospital, I was very comfortable with this device, but I wanted to make sure our staff was. Now, the team lead had been a specialist in wound care, and so was very comfortable with this as well. We walked down to the emergency department and actually spoke with the physician in the emerge, spoke with the patient around the care needs, and we were able to keep the patient in Kemptville rather than transfer them to a tertiary center. And the patient looked at us and said, "Thank you. I'm so happy I get to stay here." And I said, "I'm so happy that we get to keep you," because she was just lovely. And she ended up writing a letter to our patient relations nurse just to say how much she appreciated that. And our team lead was in tears because she felt so grateful to be part of this patient's journey and to be able to make an impact. From that, we have enhanced our education for that device, learning how we can and exploring how we can bring that type of care to Kemptville so we can continue to keep people in their home hospital as opposed to transferring out.
That's a
You know, those are great points, from Katie and Brittany. I just want to focus on a word, a key word that was mentioned by Katie a minute ago, and it was complaints. We don't look at them as complaints. We look at them as learning opportunities. And I think the staff are more likely to embrace change, embrace the opportunities to be better, because this is what better looks like. Taking a learning opportunity that we get. We love getting the compliments, and let me just say right now, on behalf of all of us, our compliments far outweigh the learning opportunities. But we look at them as a learning opportunity. And when you frame it that way, the possibilities for change and in terms of getting better are limitless, and our staff know that. And it's not really something they're penalized, or we're penalized as an organization. The more learning opportunities we get, the better. That means we're engaging not just with our staff in coming up with a solution, but we're engaging with our communities. They feel comfortable and free to bring some of these items forward because they know we need that substrate, if you will, in order to get better. It's a pretty interesting thing to experience.
That's great. It is a very important, framing that way. I mean, when you see, and I'm an engineer, so I look at things as, problems to solve. But if you only look at things as problems to solve, then you're looking at just that box that you can fix. Whereas if you open it up and look at the possibilities, then you're looking at a whole constellation of opportunities like those for learning and for improving. So I appreciate that point. It's great. That was a great segue to talking about, providing access to care, Katie. So I wonder if we could talk a little bit about one of the great benefits of having a rural hospital is being able to provide that care closer to home for folks. And wondering if you could talk a little bit about models or processes or just ways that Kemptville helps to provide that access close to home and why that's important.
Oh, it's so important for so many reasons. And um, I think from this, I'd like to start at the systems level because at the systems level, we know that people are getting sicker. We are needing more care in our acute care hospitals than we can keep up with at the systems level. We really need to look at providing care from an upstream and downstream approach. So that prevention, that community care, and that's where it starts in the rural communities, not just in the hospital, but in our community. Um, Frank often talks about us being an extramural hospital, and that was exactly the reason why I wanted to join Kemptville because there's so much opportunity to partner with the community to look at how we can prevent hospitalizations in the first place by learning, but also ensure that our tertiary hospitals that are providing that specialized care have capacity to do that. So if we're able to provide services in Kemptville, patients don't have to go to the larger hospitals unnecessarily. They can provide that specialized care and we can provide care at home, but also look at how we can improve care in our community. We partner with community paramedicine, home care, and most recently with primary care or family health organizations. We've been involved in a expression of interest for a primary care model, and we're really excited to hear in early January about that funding. But just the process of working through the expression of interest to build a new primary care model that is integrated, that looks at metrics that support hospital to home and then reducing those readmissions. How can we keep people in their home longer, but also well in their home longer? So looking at the importance of that extramural approach, I think is something that can be a blueprint across the province. It's something that when I was in Parry Sound, we had a very similar model. How I moved into a director position. I was a nurse practitioner and I used my master's work to develop a nurse practitioner led clinic that had 6 sites. And that was really connected with the hospital. It was also connected with community paramedicine. And so looking at that wraparound approach, that no wrong door access to healthcare, it really helps at the community level, but it further reaches to that systems level. And I'm excited what we can do in Kemptville to show what our microcosm could be at the macro level.
Yeah, and that system that Katie referred to, and Brittany works in that space as well, really links back to partnerships. And we firmly believe that partnerships are an amazing force multiplier. We wouldn't be able to do half of what we're able to do, as Brittany outlined and framed, as a small hospital without those partnerships, without not just the financial backing, but just the ideas, the willingness to work together, to really think out of the box and really redesign, we like to say reimagine a new system. And we choose partners that have that same mindset, a growth mindset, which is an important underscoring there. And we believe that without partnerships, we're lost. We often say, and we probably heard this at the board level, partner or perish. We really want to grow. We don't want to be complacent. We don't want to be satisfied with the status quo, and we surely don't want to shrink. We want to grow, and we can't grow on our own to the degree we need to grow to meet the needs of our fast-growing community without those partnerships. So they're vital, mission critical, I would say.
Yeah, we have a really unique team. Brittany's leading a ton of regional discussions from her portfolio. I'm involved from my portfolio, and so is Frank. And so I think, from coming from a small rural community, we do believe so much in the systems transformation and together. And I think that's what makes us such a strong senior team, that we are all involved. So people are consistently hearing about Kemptville, and we'll continue to do that.
Well, and now they will on the
Yeah.
podcast.
Yeah, you took the words right out of my mouth, Katie. I was going to say the same thing. Like, I think there is a uniqueness to this senior team. You just heard 2 out of the 3 of us talk about it, and you're going to hear the third about systems. We're all systems people. Like, we really believe that that is the way to fix this. It's not isolated, right? And it's not just hospital to hospital either. Like, Katie, especially, Frank is constantly working with the entire system, the government structures, the governance structures. Katie's working with all of the clinical folks, and I'm so connected in with all of the financial funding side, which is really what drives a lot of what you're able to do. And I also wanted to mention on the metric side and call out how unique it is to have a clinical lead who is so focused on the metrics and the financials. So we have a lot that we measure on the clinical side to look at access to care, to look at care close to home. How are we doing on this? And there are some really great validated structures in our patient survey, for instance, that is standardized across the province. And CIHI does a pretty good job of recommending the different structures to the hospitals to say, these are your validated metrics that you can pull from, implement in your hospital. And these look at things beyond just the care outcomes. They really are looking at those quality of life outcomes. And it's it's called PROMs, so patient reported outcome measures. And that really does come from that patient survey. And we have a fantastic team that administers the survey and looks at them all the time. They're mentioned in our staff open forums, they're mentioned at the board. So there's a lot of oversight on that access metric, but it requires a lot of the partnership and system level to be working well, which is more about influence. It's not about control. We don't have the control over what is available in the community, but we can talk to them. We can make sure that we're all working hand in glove and getting it done.
Yeah, that's a good point. And we do have the partnerships, but when you interface two or more partners, um, I think the mindset amongst the partners would have to be one that's change oriented. We're really prone to change. You might say we're wired for change. And, but without that mindset, the opportunities are very minimal. You only do enough that you almost get discomfortable. Did that discomfort. You don't want to be disruptive too much. What I believe, and we all believe, I think I speak for all of us, that we know we need to be somewhat disruptive in the space in order to, as Katie mentioned, the microcosm that we're trying to influence. If we're not willing to be a little bit uncomfortable, that's a sign we're not doing enough. We're really tinkering. We're really staying within the realm of the status quo, and that's not good enough. It's not good enough for us, and surely it isn't good enough for our patients.
No.
And that's why we're in business. We're not a life support system for people's jobs alone. It's important for people. People need money, but people also need a work environment where they, I believe, could have their purpose and their why exercised, and people want to make a difference. We all enter this space, health space, to make a difference. Personally, I'd like to do a bit more before my career ends. I haven't exhausted the opportunities yet, and I believe working with these two excellent leaders will be able to really push the envelope even more.
Amazing. And you guys are amazing at partnerships. I want to unpack that just a little bit more. So you've talked about this aptitude for partnerships, recognizing that you want to be a little bit uncomfortable. You want to look at partners who also are looking to drive change. What other kinds of keys to success have you seen or experienced in terms of your approach for partnership? And it might be a little bit different depending on what type of partnership it is, whether it's more operations or funding related, or something that is with like the direct local community, or within like provincially, like thinking through. And what other kind of keys are there that you found that might help others who are looking to partner?
Yeah, maybe I'll just offer one tip, if you will.
Mhm.
I think you need to take a bit of a pause when you enter the partnership opportunity and put your own interests on the back burner for a second, or maybe a minute, and really try to understand, emphasis on the word understand, what the partner's win is, what their value proposition is in that partnership. If you're solely focused on what's your gain, what's in it for you, I don't think that enterprise is really going to be, serving all parties involved. So you need to say, okay, we're pretty clear what we want to get out of it, but what does partner A, B, and C want to get out of it? And until you understand that, you shouldn't try to make yourself understood. You really have to understand where they're coming from. And I learned that from my grandfather. He didn't he believed in the win-win, but he believed you have to earn it. And you really have to help your partner achieve their gains, and yours will come a little bit more. It may not be automatic, but it'll have a lot less friction, because they're going to be working with you to realize your gains, because it's really some type of symbiotic relationship that really isn't in place that creates that win-win. It sounds like a great slogan on a t-shirt, but it's a lot of sweat equity. You have to put some time in.
Nice. Was your grandfather a businessman? What did he do?
He was a coal miner in Cape Breton, Nova Scotia,
Neat.
immigrated from Malta in the early 1900s. And looking back, he was the wisest person I ever met. I learned a
That's
lot from
cool.
my grandfather.
I hear a
Nice.
lot of mentorship stories from his grandfather.
Yeah, that's amazing. I love
Yeah.
that.
Absolutely. I think so for me, like it really does come a lot on the funding side, but I think there's a lot of tables that you sit at as an executive that can be overwhelming and time consuming, but those are where the connections are made. And I definitely see a difference in the, the CFOs or the CIOs who make the time to attend those tables and those committees compared to the ones who don't, and the ability for them to execute on some of the ideas. And it takes repetition too. There's a little bit of wearing them down with repetition, and a little bit of, if you've seen the movie Inception, just planting those ideas deep in the psyche. And then when they come back up 6 months from there now and they're saying it like it's their idea,
Yeah.
I think that's where the win is, right? It's always my goal for it to sound like it was someone else's idea and not to take the credit. I'm never the person who's going to stand up and be like, well, no, like I said that 6 months ago. Let's all
Right.
remember that. It's really about like, yes, no, absolutely. That's such a fantastic idea. Wow. I'm probably giving a little too much away now, but
There are a lot of people wondering.
Reply to me. No, but I think that to Frank's point, like he's talking about that from a business perspective, but when you look at that from a psychological perspective, that's empathy, right? What he's talking about is empathy. And you can have empathy for people, but you can also have empathy from an organizational perspective of putting yourself in that other organization's shoes and knowing what's going to make sense in that middle ground. And I think that your point around symbiosis is so accurate. There is what works for me and there is what works for you, and there is what is a compromise, but there's another thing in that middle there that is actually a synergistic element that is actually better than what it would be for either of us. And it doesn't have to be a compromise. It can actually be a true win-win where you are making something better for everybody. And that's, I think, what takes time, which can be really difficult in a 4-year political cycle, especially when so much is driven by funding. And right now, despite the fact that we've just come off of a pandemic, the shift towards international trade being the primary focus of all governments, and the stressors of inflation and just the overall trade environment that we are in has really taken that focus away from healthcare and meant that we are being forced to look at the financial situation under a lot of scrutiny. And that can make for very stressful situations, but it can also be an impetus for change and force some conversations that may not have occurred otherwise. And so I think trying to keep that lens that there is a win here, we can get to a better place, is the way to approach that, and to continually iterate. Like I'm a big fan of making small iterative changes and getting buy-in that way too, right? Like if you can build trust by showing a new partner,
Right.
hey, like I said I was going to do that thing and then I did it and look, it turned out really well. That is going to slowly build up the ability for you to do bigger and bigger things over time. And next thing you know, you're 2 years down the road and you have this great trusting relationship where you can have really open conversations and you can get a lot done.
Yes, absolutely. The importance of trust to driving change and making those things happen, and how to get that trust as well.
Trust is key. I love that
Yes.
word, Amy. And I met a senior executive here my first day on the job. Actually, I went for a little road trip. I like to meet people in person. My team knows this. And I went to speak with Dr. Jack Kitts, who was the CEO of the Auto Hospital at the time. This was back in I think mid 2015, and we were talking about partnerships and talking about integration, and had a lot of passion for integration and partnerships as well. And we talked about trust, and I'm not sure if it was Dr. Kitz's term or phrase, but he made it his own. He said that integration will move at the speed of trust, and I believe that wholeheartedly. That is so important. It takes a long time to build it. The flip side of that, it takes a couple seconds to lose it. But I believe that these two colleagues here, Brittany and Katie, are doing a tremendous amount with their colleagues and their contacts to build that trust. I see it, I hear it. They're not just influential here in the Kemptville, Ottawa area, but they're bringing value to the provincial stage. I hear great things about Brittany and Katie from my colleagues in Ontario. And listen, when I say Ontario, meaning Queen's Park, Ontario, I just want to say one thing before, I would be remiss if I didn't mention it. I'm encouraged and inspired each and every day by how receptive the center is to change and to new ideas. They don't have all the answers. Sometimes we look to Queen's Park for all the answers. They don't have the answers. But I believe over the last couple of years, 2 years, that they're turning to the field to say, look, we don't have any answers. It's not good enough to do absolutely nothing. What ideas do you have? So when we brought ideas forward to them for some of the work we're doing, whether it's integration model for ED services or nurse practitioner-led clinic with a host of partners to address the primary care challenges that we face, they're all ears. They seem like we want to learn more about the ideas because we don't have all the answers at the center. So I think not only are we influencing here, but we're influencing at the center to a degree. And I believe, and I'll give one final plug for small hospitals. They can go on all day about small hospitals. I believe we're a well-kept secret. We're underestimated each and every day. And I came into that realization honestly because I worked in the GTA, I worked in Hamilton, I worked in London, I worked in large academic health science centers, the biggest centers in the country. And I saw what the small hospitals were being considered as just almost like an inconvenience, just like we need to support them. No, I think small hospitals can support you, big hospital, if you just sit down with us at the table and again, using that word, reimagine how a new system could be created.
Mhm.
That's what's exciting, and that's what inspires me each day, the opportunity for change.
Yeah. I think for me, just going back to the partnership, I had a really unique opportunity to leave an organization that I had worked in a community for 12 years in one region and move to an entirely different region. I really had to approach my new role with curiosity. And so we talk about trust, but we also talk about curiosity. Just going back to what Frank said about really wanting to know what our partners, what are the challenges they have. And so over the last year, I've had that privilege of getting to know a community, getting to know our partners, and really approaching from that curiosity and understanding where are their pressure points and how can we leverage our influence as a hospital. Because sometimes the smaller community organizations actually don't have as much influence as maybe a hospital does. And if we don't have that influence, we have partners at larger hospitals or Frank's incredible history at the ministry. And I mean, the folks that he has on speed dial um, are such a great way to influence change. And so when we talk about just going back to that blueprint includes our partners and the curiosity around what makes sense for the community and how can this be applied again back to that broader system.
Wow,
Yeah.
amazing. That's great. With all of the information that you're all taking in, I mean, it must be hard sometimes, and tell me if it's true, to kind of prioritize. So if you're empathizing kind of with everyone, and if you're at many, many tables and you're building trust everywhere, it's hard to do that, and be everywhere where you're needed all the time. Any thoughts on how you prioritize some of this?
Caffeine.
Yeah.
Yeah.
I'm a fan of
Got you.
caffeine.
Yeah.
I think just again, just coming into the organization as a new player, um, there's really that ethical lens that's applied. So when you look at the priorities that we had even a year ago, they've shifted. They've shifted because of the system, because of financial implications, but also patient needs. And I think that's why it's so important to have such a strong team. Oftentimes, finance and clinical, and this is not our case at all. I want to highlight that finance and clinical don't often see eye to eye because clinical is saying, I need this service. And the financial department is saying, well, we don't have the money. How are you going to come up with that? And I think that's where I really gained my interest in understanding. Okay, how do I bring this to my CFO and say, okay, how can we get this funded? Or I have this great idea. This is what I'm thinking. And with Brittany having that clinical background, and understanding that. So between the two of us, we can triage on the spot to say, okay,
Mhm.
this is actually a priority right now, and we'll get to this in 3 months. Um, and just going to Frank and his leadership style, he allows us to really do what we do best. It doesn't get in the way, but really helps through that guidance and mentorship, and really reaches out when we need him to, when we need him to call speed dial, um, for what we're prioritizing at that minute, if
Yeah.
that's where we need to go.
Yeah.
Yeah, maybe I'll just jump in. I know Brittany, I just want to give Brittany a prompt here. Brittany brought the mindset of priority setting and
Mm.
managing expectations, and she did it from a real honest place that I really admired from the beginning. It was about the staff, the people we work with. She was concerned about their health and well-being. There's many concerns, but that is first and foremost. You can't say, your people are your strongest asset without spending some cycles, psychologically thinking how you're going to maneuver everybody down the road. Because I was chatting with someone not long ago and they asked me what business I was in. And I thought about it for a second and I said, we're in the people business. We just happen to deliver healthcare, and that is true. But in terms of priority setting, and then maybe I'll talk about the strategic high level and pass it to my colleagues. When we do set priorities, we have to consult our North Star, our compass, if you will, first. It's our strategic plan. And there's two major chunks in the strategic plan. I won't get into chapter and verse what they are, but we have strategic directions and a set of strategic priorities. I take those priorities and I fashion my CEO performance goals as my colleague on the medical side, our chief of staff. But we need to figure out what we do. Does it actually make a difference,
Mhm.
relative to our strategic plan directions? And the final point I'll make on this is um, not only those two large lenses that we look through, the strat plan oriented lenses, we have to take a look at three really important lenses. The first one is whatever change we're doing, work we're undertaking, is it making a material difference to the way we treat our patients and the services we offer patients? That's why we exist. The second lens is it making a material positive difference, we hope, in the lives of our providers? Are we making their work life not only enjoyable, but are we supporting them? Are we giving them the tools and the resources they need? And then the third, and this is a key to all of our partnership extramural hospital approach, is it making a difference within the systems context, the regional context? And if we're getting negative scores in any of those three lenses, aside from the strategic planning lens, then we need to go back to the drawing board and tinker with the plan, because it's not really hitting the mark. And one thing we don't want to do is cause any more burnout amongst our staff,
Mhm.
and perhaps I'll stop there and pass it on.
Yeah. Um, I was gonna make a joke, and then Frank went and was so eloquent. So,
No.
no, I was gonna say this is really a do as I say, not as I do situation for me, because I tend to take on way too much myself. I'm doing a master's right now. I've just accepted a co-chair role of the Financial Leaders Network for the OHA. I'm a CFO, I'm a mom, and I am forever doing too many things, which makes prioritization tough. But I would never give that advice to my own staff. So it's very much a do as I say, not as I do. But um, psychological safety and mental health and well-being has been such a focus of mine throughout my entire career. And I think that, that has to come at the top of the overarching sort of cultural perspective when you're talking about prioritization. I think during the pandemic, we had all of this reporting around HHR pressures, so health human resource pressures. And we talked a lot about burnout, particularly of frontline staff, but in the background, there was also tons of burnout on the administrative staff and the manager staff as well, and executives. We had a lot of executives leave the system. And that was addressed in this very band-aid approach of like, you'd see all of these social media posts about like doing yoga and meditating and taking mindful moments. And um, it became almost memeified, right? It's like, oh, we're sorry you've had a bad day. Here's a pizza party approach. And I am very passionate about if it is a system issue, it should be a system fix.
Mhm.
So if people are facing a workload issue that is causing burnout in their department, then we need to adjust the actual situation that they are facing that is causing the burnout and not just give them, a bigger mental health budget on their benefits so that they can go and deal with that in therapy. Like that's not the win here. The win is, and we just did this, we restructured our nursing ratios on our inpatient unit, despite the fact that that was a cost at a time when we are facing financial hardship, because the reality is you end up having to pay for that one way or the other. You either have turnover and retention issues, you have increased overtime. We were having to pay agency nurses when people left
Mhm.
because we were having to backfill. So the care is there no matter what, right? The demand doesn't stop. People walk in through our ED, they get triaged, they go to our inpatient unit. People's health doesn't pause just because you are having a staffing issue. And so if we are invested in maintaining our HHR personnel in the system, and not just at KDH, but in the system, you have to make sure that you aren't cutting back for the sake of dollars at the expense of burnout and retention of your staff. And that can sometimes sound a bit cynical because you are putting that dollar perspective or that metric perspective, but it comes from a place of compassion for me. It really does. Like every single person who comes into healthcare could have chosen a different career. This is not an easy job. There are much easier jobs out there. And the people who are here are in it because they want to be here. They are passionate about caring for people and they deserve to be taken care of too.
Mhm.
Um, Going back to sort of the more structural stuff that Frank spoke about. So we've worked really hard at making sure that our strategic plan cascades all the way down
Mhm.
through our organization. And we do this through formalized goal setting. We do this through performance reviews, through recalibrating throughout the year. There's been pretty big changes this year worldwide. I don't know if anybody's noticed. And that has really changed what we need to prioritize. We've suddenly had to deal with governments handing down new directives around what we're allowed to purchase because we are a government funded organization. Now we have to prioritize buying Canadian. That meant that got kicked to the top of the list, right? And so there is that constant flexibility that is required, but you still have to say, okay, really, how does this tie back? Does this actually align with our mission? Are we doing the right thing?
That's right.
For sure.
Coming from a CFO who spoke at a healthcare conference around psychological safety and mental health and well-being within our staff, I think it just highlights the uniqueness of our team.
Absolutely.
And one of the things that I also want to shout out to Brittany about was the use of technology and how, and we're wired for change here, and I think that was something that I really appreciated coming into this team, the use of AI very early adoption of AI to enhance our effectiveness as a team. We know that digital solutions, so they're supposed to make things more efficient. It's not. It takes a lot more time to document on
Yeah.
on Epic. And so looking at how we can enhance the providers, our leaders, using technology such as Copilot. In the emergency department, we're utilizing something called DAX Copilot, which is helping dictation for physicians, looking at how we can do that throughout the organization. And we know that all of our partners are doing the same thing, but we really are an early adopter. I've had a few emails recently for folks looking at, how can we use Copilot? And I was like, well, Brittany created an entire policy around this 2 years ago. So just really being able to leverage that technology and identify where those pressure points are. I also just want to go back to your comment about the strategic goals and from a clinical lens and Brittany's financial lens, when we look at our scorecards
Mhm.
and that trickle down from the board level to the unit level, we also have that cascade up. So when there's
Mhm.
something happening at the unit level, we have scorecards. We look at our alternate level of care, our falls, increased falls leads to increased length of stay, leads to increased cost on the system, sometimes overtime, sometimes injury for staff. So it impacts all of us. And so what we've done with all of our scorecards, including the balanced board scorecard, is align that with the strategic priorities. So
Mhm.
all of our metrics also at the granular level tie into that strategic plan.
Beautiful.
I I just want to add to, in healthcare, we do have a unique situation where there are real, genuine emergencies in our line of work, which isn't the case in every line of work, right? So prioritization on any given day can look really fascinating because it can turn on a dime, right? And
Yes.
and it can come from the strangest places where, I've had to pull together an incident management team because we have a overheating wire, but that wire is needing to be monitored because it's a fire risk. And so we need to get this in, but we can't replace it. We can't do any work on it because that wire is driving our Epic system, which is then going to affect patient care, which means that you can't deliver medicine because if the system goes down, you have to go into downtime procedures. So, like, the knock-on consequences for something that in another organization would be relatively minor
Mhm.
is so profound in a hospital because there are truly life and death consequences to it.
Yeah.
So prioritization is really interesting, and it's funny because when I was an accountant, and I was doing audit, people would get so stressed, and I had this health science background, so I had always had this mentality of, like, dealing with true health issues and true emergencies, and I used to tell my teams, like, "Look, nobody's gonna die if we don't get this done."
Yeah.
And I don't get to say that in a hospital. So it
Yeah.
gives a different level of accountability and urgency to things, and it puts things in perspective too. Like, when somebody is panicking about something that isn't life and death, we do get to say, like, "Hey, like, let's remember the business we're in. Let's remember that it's the patient at the center, and are we able to deliver care right now? Are we safe?
Mhm.
Okay, well, everything else is gonna be all right. We'll work it out,"
Mhm.
right? And just level setting.
Absolutely. I had a CEO who is a nurse as well, and she used to say the same thing,
Mhm.
"Nobody's gonna die
Yes,
if you didn't, change this to a spreadsheet or whatever it was,"
exactly.
right?
Yeah.
So I appreciate that lens, and it's a balance, and I mean, it sounds too like the clarity and the sharpness on understanding what, the current priorities are is helpful when you need to change those priorities and
Yes.
rebalance. So everyone has kind of got to be, clear on that as
Mhm.
well. We talked about technology a little bit. Brittany, thanks for mentioning some of the initiatives in terms of, sorry, Katie, in terms of AI that Brittany has been leading. Let's talk about technology for a little bit
Mhm.
as an enabler, because technology is something that can cause friction, but it is also something that can really kind of smooth things out and really enable and magnify the impact that can be had, magnify kind of efficiencies that can be had as well. You've had a number of changes with implementing Epic over the last while, and it was a successful project. Any advice to give to others in terms of their Epic projects, or how did your experience go with
Mm.
respect to Epic? What are some of the benefits that you're seeing now, and any other comments just in terms of technology risk, cyber risk as
Mhm.
well? I'd love to hear about as well, but maybe we can start
Yeah.
with the data side of things.
Yeah, sure. So, yeah, I'll start with Epic, and there's a whole other side of on the cyber risk and security
Mm,
piece. But, I spoke a little bit before about the unique geography of our region. So we are a small rural hospital in the outskirts, but there is this sort of horseshoe of small rural hospitals around the center of Ottawa. And the Ottawa hospital, therefore, is really well positioned to be a hub and spoke model. And that is the model that we used when we were implementing Epic. We were part of a second wave implementation that was led by the Ottawa Hospital. So they first went live in 2019 with 5 partners. And then in 2022, so November 2022, we went live with 2 other organizations. So we then had 8 organizations part of this thing called the Atlas Alliance. And because we were part of a second wave, it was a really different type of implementation than what a large system would go through for the big bang,
mhm,
where Epic comes in. And I was part of that actually in 2017 when I was at Sick Kids Hospital.
mm,
So I saw the difference. I saw that big bang approach. You're going live literally gets turned on. You have to have everything working that day. You are inundated with people from Epic. The organization itself actually comes in to support these implementations. You have so many consultants, so many project managers. They have SMEs, they have credentialed trainers, principal trainers running around the place trying to solve problems. For us, there was that, but it was so condensed, and it was you had the system turned on already. So we were turning on our version of it and making sure that everything was working the right way. And you had a lot of these sort of small hospital, big hospital differences of like, okay, I understand that in the Ottawa hospital, you have a different reception role and a nursing role and a this role and a this role. But at our hospital, that's one person who's doing all of those things. And so they can't be signing in and signing out under different roles. You need to create one role for this. I think that we did, it was an exceptionally successful go live. Like, I'll just say that off the bat. And I think that the patient care benefits of having Epic in place, especially in an integrated instance like we have in the Ottawa region, is it's hard to underestimate the impact of that for the patient. Because now, when if you are transferring somebody from KDH to TOH, that chart follows them and that history follows them, and the doctors who are on shift can see everything that is happening. Um, and I think what's nice is between 2017 when Sick Kids went live and 2022 when we went live, there has been a recognition that it is not an efficiency tool. So in 2017, there was a lot of rhetoric when Sick Kids was going live that like, oh, this is going to make your life so much easier. And it was said to nurses and it was said to physicians, and Epic does not make their life easier. It, if anything, makes it slightly harder, but it is a quality enforcer. And physicians, especially, it puts so much of the onus on them. So it can be really, really challenging for them to buy in. And you need to make sure that you have the supports in place, both during that go live, like the at the elbow support of making sure that they have their solutions right there, because you can never stop treating patients. You're still treating patients while your go live is happening. But you also need to invest in the education on a go forward basis. And I think that is something we didn't do as well. And we, not being necessarily KDH, but we as a system in Ottawa have not put the systems and structures in place to do continuous onboarding, continuous learning, making sure that all of the updates are reaching our end users and that they're getting the training that they need on an ongoing basis. So we're going through that right now. There's a really, really healthy governance structure involved in the Atlas Alliance. And there's a lot of business cases on the table right now to make sure that frontline staff get the training that they need on an ongoing basis.
Wonderful. Thanks so much for that. It's good to hear sort of what's continuing on as well. And before, I guess, before this implementation, records wouldn't necessarily have followed patients
No.
at all, right? Just to understand the previous state and
Yes.
what's possible now.
Yeah, for us, we were mostly paper-based. There was Anser was sort of a predecessor. We had some electronic medical records, but for the most part, it was paper. And I've seen some of the physician's handwriting. It's not good. And
It's everything we think.
It's a myth for a reason. It's actually true. The physician handwriting is very challenging to read, and we actually run some competitions in medical records week when we
Really?
do recognition. Yeah, where we give them interpretation challenges of physicians' handwriting. It's actually really fun, and we get people who are not in health records to try to interpret the physician's handwriting, and we compare.
I like that. It says something about the culture too.
Yeah,
That's
but there's, in order to get a record transferred, you're faxing it.
Yeah.
So
Yeah.
Yeah, no, that's well said, Brittany. You just mentioned about culture again, and I love talking about culture, and I know you're passionate about culture and culture builders.
Mhm.
And as I said earlier, we put a lot of stock and investment in our people, and we look to them. They're the future leaders. So, how do you identify an emerging leader? That's something I think about a lot. There's more of a systemic approach to it. I look for people that model positive behaviors. They embody the core values of the organization. They're honest communicators. They're ones that are very open-minded to trying something new. They're innovative. They engage others. They definitely read our strategic plan because they can recite, mission and vision of the hospital. And it sometimes is difficult to only identify one. We have so many great people today, and I think they're taking tips from Brittany and in Katie. They're great role models, and I'm seeing the next wave of leaders mimicking their behaviors. I never saw that before. This is the strongest senior leadership team I've ever had the pleasure of working with. I've had larger teams, but not anywhere close to the substance and the quality that these two individuals bring. And as a almost like a paternalistic approach, I look with a source of pride at what we're cultivating in the organization and what we're building. And these folks are culture builders. It can't be we can't be really the only purveyors of culture, senior leadership team and the board, with all due respect. We need to look at everybody in the organization as being ambassadors, as being culture builders, looking at recruitment. Who best to espouse the benefits and virtues of working at KDH than our people? But they can't be forced into doing it or coerced into doing it. It has to be innate. It has to be something that they could speak to over a coffee or in a grocery store or whatever. And we're getting there. And my first 7 years at the hospital, we were making inroads into that area, really spending time on building those culture builders or nurturing those culture builders.
That's great. So many ways to reinforce that
Yeah.
that I'm hearing, as
Mhm.
well through how you interact with them and how you listen and how you have them participate in design and learning and all of those things.
Yeah, and
It's
if I
great.
could just actually go back to the
Yeah.
technology piece and about that. So Epic, just going back to Epic and the data that we can pull from there is
Mhm.
just amazing. And so quality is under me, and I love data. Everybody who knows me. I'm a data geek because I think it just tells the story.
Yeah.
What I love even more is that our managers and our teams love it even more than I do, and love a good
That's a
spreadsheet
good
on.
data
I
culture.
know it's really cool.
Yeah.
Our emerge manager, when we're looking at quality, for example, um, the left without being seen. So we were seeing our numbers were going up, our left without being seen numbers. We could see that from High, but also from our Epic data. And with that goes funding. And so it's an opportunity for us to improve that, but also look at the reason. And so we were hypothesizing, saying, well, patients have access to my chart and they could look at their chart. Maybe once they get their results, they leave the emergency department. And our emerge manager said, well, let me just do some data review on this. And in fact, it was directly correlated with the time to rooming and physician initial assessment. So we recognize that it's not actually the patient looking at their x-ray result or their labs that come in, but it's the time to which that patient has attention paid to them by the nurse bringing them into the room, by the physician saying a quick hi. And so we were able to pull together a quality group, including physicians from KDH, the Ottawa Hospital, who are also participating, the physician leaders there, our managers, their directors, and we were able to come up with an action plan to reduce our left without being seen, to improve that time to rooming, looking at the quality of the checkpoints that are happening in the emergency department. And within 1 quarter, we were able to reduce it significantly. And we've already been able to get back to the funding level that we should be at just by looking at the data. If we would have gone with our initial hypothesis and not actually looked into it, we would have been incorrect.
Yeah.
And that's where the data really helps. But also having people who are super excited to do that and to do that
Yeah.
work within our teams.
Yeah, that's where that people and technology
Yeah.
part really comes into place to build that foundation
Yeah.
for everything that you can continue to do in the future and improve on in the future.
Yeah.
That's amazing. And then, so what about on the cyber side of things? Since
Yeah.
we mentioned that as well. I mean, you might be. I mean, smaller hospitals are often challenged with leaner teams, fewer redundancy, less redundancy in their systems, maybe less resilience in some ways, just because of funding challenges or constraints that you're working with. Are there any decisions that you've made with respect to your approach for cyber or cyber controls that have had sort of an outsized impact with respect to, where it's really helped?
Yeah, this is such a deep topic
It
for
is.
us.
Yeah.
There are so many decisions that happened prior to my arrival and that were so difficult to grapple with. It took me about 2 solid years from the time I started to really get to a place where I felt like our organization was in an okay place from a protection and risk.
Mhm.
And we we'd had a review, I think in 2019 by KPMG,
So yeah, 2019.
um, that came in at the board's request and reviewed our cyber risk perspective and our data risk perspective. And we had been starting to implement that. Um, but we did have a cyber incident in 2021, and we were forced to work from backups, which had not been done well, and we lost a huge amount of data. We went into downtime procedures for a number of days. This was just prior to me joining. And when I joined, the ramifications of that incident were far from over. We were still going through and replacing servers and updating things and really working very closely with our insurance company who was helping us with the recovery. And some huge learnings both for me professionally for my own skill set, but for the organization as a whole. And of course, anytime an incident like that happens, you come out stronger,
You do.
but you do hope you never have to go through
Mhm.
something like that. Um, and there have been a number of small hospitals especially who are being expected to have the same technologies available, especially to the clinical staff, but also to patients, um, but don't have the funding to create a really robust team. And even with the funding, the amount of scale that you require to have a team on site that is well versed in this type of stuff is not feasible for the size of organization we are. And so a big thing that I think Ontario is doing very well is these local delivery groups, LDGs. And so we have ours is the only one that got creative and called themselves East of the East. Everyone
East
else
of the
is
East.
just everyone else is just a plain Jane name. Ours was the only one that was creative. And I was like, yeah, go us. We were a little bit interesting. But that has created a set of standards and protocols. We get all sorts of notifications of risk. We respond to those. And along with that, we also have this really strong partnership with the Ottawa Hospital. They actually are now we leverage a managed service agreement with them for our IT. So we still have the same people who were our IT people originally. They stayed employees, they didn't stay employees of us, sorry. They stayed on site and they became employees of the Ottawa Hospital. And now suddenly we have the scale to access that entire team and ensure that we are following the same protocols that a hospital that is $1 billion in expenses every year instead of 30 million. And that has taken us to the next level. Um, Epic also really pushed us. So the level of infrastructure that is required, IT infrastructure that is required to run Epic, uh, we did not have. We were running cables like a month before Epic go live, going, oh, the amount of data that's going through this is going to completely burn us out. Like this is not a feasible situation. We were having to create new Wi-Fi access points because all of the WOWs, the workstations on wheels, were having to go into patients' rooms, and we were, running around with these WOWs, making sure that they were staying connected at all times. But it's forever iterating. And I remember when generative AI first came out, the sophistication of phishing emails suddenly went through the roof, right? And so now you have to focus on that. And it goes back to our conversation around prioritization. And so you're constantly having to reevaluate, and we're insured through High Rock, which is specific to the healthcare sector, and they have such a great advisory arm. So anytime I do have a question that I'm unsure about, their familiarity with risk that's specific to our industry is so phenomenal. I have so many experts in my back pocket that I can talk to, and that's really what allows me to sleep at night when it comes to cyber risk.
That's so great.
Yeah.
Really appreciate the practical and operational realities, and helping people to understand, what it is that those challenges are and how we are meeting those challenges. So that's terrific. Thank you. And I know that there's a lot more we could say
Yeah,
about
it's a deep topic for sure.
Maybe we'll come back to that another time, but really
Mhm.
appreciate that because we talk a lot about cyber on the show, but really understanding it from the inside of an organization is really important as
Mhm.
well for people.
Maybe just on that technology piece, I also want to speak to the importance of those partnerships from the clinical perspective. So, um, coming from a hospital where we had our own IT department that was just at the hospital, it was really difficult to implement a new BP monitor, a new bed that was tied in with the system because we needed IT to be on board. And if IT was prioritizing running wires for a new system or doing something, we didn't have the leverage of the additional team. Where having that partnership with the Ottawa Hospital and that larger regional approach, we have people that we can call on so that we're not missing the opportunity for a new piece of clinical equipment or a new surgical approach. We're able to implement that through that partnership, and leverage the other resources that might not be in house.
Amazing.
Yeah.
That's great. Thank you.
I know, and I'll say one other thing on cyber. In the larger organizations, I've noticed that because IT teams are so isolated, they have such a level of specialization, you can sometimes get disconnected from the operational realities on the front line. And in a different industry, again, going back to this like life and death in healthcare, uh, if you make it inconvenient for somebody to do something, you're going to get errors. You're going to get people trying to bypass the system. There's a level of system design psychology that has to be applied, and you're going to cause problems for yourself. But at the end of the day, you can kind of work through that. If you make a barrier because it is more secure from a cyber side, but it means that a physician who only comes in once a month has to wait 2 hours to get access to Epic because it's so tightly controlled,
Yes.
you've now created a patient safety issue.
Yeah.
And so keeping that front and center when you're making these cyber decisions and controlling for not just the risk to your system, but the risk to the patient and keeping those things balanced is so, so, so important in healthcare.
And it sounds to me like, I mean, you guys have some overlap, right? In
Mhm.
terms of your ability to understand each other's
Yes.
worlds so that
Yes.
you don't become siloed, right? It sounds like that becomes reflected in your teams and how your teams work together as well, which is
Definitely.
so important to making things a reality and to smoothing kind of the path for that.
Absolutely.
I
That's
love that you
exciting.
use that term silo because I actually wrote that down earlier when
Oh.
we started talking about partnerships and the fact that so often teams are siloed, organizations are siloed, sectors are siloed. And I
Mhm.
think, this is reflective of our team just as it is within our partnerships. We don't believe in silos. We believe in breaking down those barriers from a clinical operations perspective, but also within the community partnerships that we have. And so when there are the barriers that are happening, for accessing healthcare or accessing technology, we look for ways to break down those walls and build those bridges between our partners. And I think that's why we work so well together and we work so well within the region because that's how we all operate.
Mhm.
Amazing. And is there anything that we can add just from like a personalized care perspective? So we can add in a lot of technology, but I've had conversations where for some it becomes kind of a barrier to, really getting to know people or knowing their
Mm.
names. And you guys are so great at that at KDH. I think continuing with that compassionate and that personalized kind of care piece. Is there anything that you might say about what you're doing in order to maintain that? Because that's not something that we want to, give to AI, for example, necessarily either, right?
It's a great question. If I can just add just
Yeah.
one thing, no low tech,
I-
a low tech idea, and I'm really proud of this fact. I'll lead with Kemptville District Hospital was the first hospital in Eastern Ontario to put in place a patient and family advisory
Mhm.
council. I'm really proud of that, and a lot of the technology that both Brittany and Katie alluded to. They enable a lot of the ideas and the kernels of opportunity that come from our PFAC committee, the patient and family
Mhm.
advisors. There's a few folks on there that have engineering background, super bright people, as Katie mentioned earlier. But the essence of their ideas are very basic. It's just human nature, human
Yeah.
kindness, being patient centered. Now we could use technology to address it and improve it, but just the ideas of having another set of eyes, lived experience, as we call them, factored into the equation of getting better, of evolving, of adapting, of pivoting. Without that intel, we wouldn't really know what direction we should be heading in. And they're one of those lenses, as I referred to earlier, the lens of making a material difference and change to the patient experience. If you're redesigning something, that comes from oftentimes ideas that the PFAC committee would bring to the table.
Mhm.
Amazing. This topic jazzes me up because our PFAC, I mean, they were already strong when I joined, and one of the things that our patient and family advisors have wanted to do is be more involved at the committee level. And when we look at standards of quality, the system should be designed by patients and families for patients and families, and we're living that. So we mentioned Ron and Sue, who are very visible PFAC members, but other PFAC members, and we've actually embedded patient and family advisors into as many of our committees as we can, and we have a map for that, so that when we do have some new program that we're developing, we have patient and family advisors at that level. Yesterday, we had our Equity, Diversity, and Inclusion Committee. We have PFAC members that sit there and, in fact, are leading the education rollout based on their experience, based on what they saw as patients. On that committee, we also have an ethicist from Champlain Ethics Group. We have a direct line to an ethicist at any minute. I can call them. Any one of our managers call them. We get a report every month to say, this is how many consultations we've had and what the topic has been about. And I think that's really unique to our community, but it's also really unique in that it continues to evolve based on what the needs are. One of the things that I think is also really important is the visibility of our leaders from that patient-centered approach. We talked about our patient relations coordinator, but Frank offers his own phone number, his email. I do, Brittany does. We all do walkabouts, and we will meet with patients, but so will our physicians. There's not a brick wall to where the physicians, won't address a concern. Our patient relations nurse has done an incredible job at developing a pathway that if there is a concern that's brought forward where there needs to be a bit of a clinical voice or clinical review, our chiefs of the department, our chiefs of staff might get involved and have that direct conversation. So patients do feel like when they bring forward a concern or even a compliment, they have direct access to leadership. And I think that's, again, going back to the uniqueness of a small organization. We can be visible. We can walk down the hall to go get a coffee and have many conversations in the hallway, which we do.
When I'm introduced to a new PFAC member, invariably, almost to a person, they say to me, I don't know, I'm not sure if I could add any value. I don't have any healthcare experience other than my lived experience being a patient. And I said, well, that's important, but what we look to you for is continuing your innate sense of curiosity. We want you to ask questions. We have a gentleman by the name of Ted on our PFAC committee. He doesn't have a healthcare background. He's an engineer by background. You can relate to this. And he asks us great questions. He just always wants to know why. He's always asking why. Okay, we do it this way and this reason, rationale. Well, why do you do it that way? Well, we can't do it the other way. And he said, well, why can't you do it that way? Like, he's always asking why. And he's so curious. He pushes our boundaries in a very positive, healthy way. And every single PFAC member brings that. And I think it brings the richness to the experience at the PFAC table, and quite frankly, makes us better.
So you probably saw my eyes light up when you asked the question, and I was going to go a completely different direction than these two.
So I wanted to get my 2 cents in there first.
I know.
I'm good.
I like AI. It's the AI. Yeah.
You're trapped in here now with
Yeah,
me.
exactly. No, I think that we've been in this weird technology phase for a long time where technology actually created a barrier between clinicians and patients, right? And you see it just, even in like the imagery of what a physician is doing. It used to be very like direct eye contact. You're talking to the patient, and then you'd turn around and you'd write a little bit in your chart and you'd go back, or you could have your notepad in front of you, but it was very minimal documentation. And then you'd write some chart notes afterwards. But while you were with that patient, you were genuinely with that patient. And now, especially with how data driven the charts are, most of the time those conversations are happening with the physicians back facing the patient. And they are interacting with the computer, and the computer is dictating what questions, and then the physician is briefly turning, asking the question, and then typing as the patient is dictating. And that makes for a much colder experience. The patients don't feel that level of empathy, and the providers aren't liking it either, right? Like, suddenly how fast you can type becomes a critical success factor, right? That's not what they got into this business for. And I find with the pendulum is finally swinging to the point where we have ambient listening technology, and I am so excited. I just think it's the best thing, and as Katie mentioned, so that's what Dax Copilot is. It's a first iteration ambient listening technology that helps with charting and note taking and coding within Epic. It's integrated, and it is a next level sophistication of dictation software that can help providers reconnect with patients. So I think the more sophisticated those ambient listening technologies get, the better off we're going to be for nursing and physician-based care, getting back to that true human connection. And those are the things that technology should be used for. The idea that you're going to have patient care provided by this anthropomorphized robot that's going to roll into your room and give you your meds is not where the wins are. The wins are in taking away the pain points that are already in the system, making that frictionless and really adding value to the human experience of healthcare. And then you see it, there's so many quick wins here. Like, that is the same thing on the operational side, on the administrative side. I use it the same way. One of my favorite ways to use AI is as a really sophisticated dictation software. I will pull out my phone, open my ChatGPT application, turn on voice to text, and just info dump. And suddenly I have this really nice note about what I'm going to do, as opposed to spending time on my computer based on how long it takes me to type out what my internal thoughts are, that I can get out way faster through voice, right?
Yeah. And I think the operative word you mentioned, you've all three of you mentioned it, is enabler, right? It's not replacing.
Yeah.
It's an enabler. It's a tool to augment and improve, hopefully, the patient experience. So from Brittany's last points, how do you make that patient physician interaction or nurse interaction or whomever provider in the system more value added? Not getting back to where we were 10 years ago. We should improve upon it. How can we leverage technology to enrich the patient experience, add value? And that's a challenge that we all face, and much smarter people than myself are working on that. These two ladies in particular, and their colleagues. And I'm looking forward to the day when we can have even a better experience than we had 10 years ago or even today. That's the promise that we're looking towards.
Well, it's gonna be really interesting just to see where we're at 6 months from now, right?
But
Things
yeah,
change
maybe it's even
so
sooner.
fast.
You're right.
Well,
Yeah.
but going back to the pandemic, I also think that we've scaled back technology quite a bit too within our own culture, because we've talked about all the benefits, but also where it can sometimes depersonalize that. And that comes with our meetings and our managers as well. And
Yeah.
so I always go back to our PFAC members, because they hold us to account. They want to have in-person meetings for Patient and Family Advisory Committee, for Equity, Diversity, Inclusion Committee. Frank,
Yeah.
we drove down to Kingston to have a meeting the other day face to face, because it's so valuable to have that. And through the pandemic, we missed a lot of that personal communication. And so I know Brittany and I, with our teams, we want to have the ability for folks to join hybrid and have that work-life balance, but it's also important that we really have those in-person connections, and don't get too reliant on the screen and the many heads in the screen, because you forget how to interact with other people.
It's true.
Yeah.
It's true. It's true. Well, I'd just like to ask a couple more questions about culture before I think we wrap up, because I could absolutely keep you in here for hours and hours. And maybe you'll come back again at a future episode. But just to build on the point you were just making, Katie, and it sounds like it probably feels very natural for all of you to connect with the staff and to help
Mhm.
the staff, feel like they're connected to you as well. But I want to ask you, for others that are out there, just, how do you help your staff to feel like you have their back, even, when there are times, especially when there's a lot of pressure, when there's a surge, when there's something that's really, really challenging that's hitting all of you at the same
Mhm.
time, kind of thing. What are some of the
Mhm.
things that you do so that they know that, and they know that they're involved, and they feel supported, and they feel like the environment is safe, and
Mhm.
even what you're doing with PFAC? I mean, if Ted and others feel like it's
Mhm.
safe to ask questions, you guys must be being good listeners, right? So what are some of the things that you do? And again, it's
Yeah.
probably hard because it feels so natural to you, but what do you do?
It's such a great question, and I knew we were going to talk about that. So maybe I'll kick it off with three things that I look for, and I know we're doing these three things really well, but could always the opportunity to improve on them. It is really transparent and honest communication. It really
Yeah.
goes beyond just tokenistic engagement. It's about openly and honestly communicating with staff. And sometimes that's a challenge for us because we want to be more forthright, but for many reasons, whether it's government directives or what have you, we can't be as forthright as we can, but we're still doing a very good job at that. The second point is a strong and visible leadership. We all walk around. We manage by walking around. I'd love to find out what people are doing, and I like to be accessible because people in the past, and I'll be honest with you, I was a little bit timid originally
Mhm.
to walk around. This was before your time, Brittany. I'm not sure if I even mentioned this to you, but they weren't respecting the chain of command, the
Mhm.
nurses. They were bringing issues to me. I don't get that. I'm all through the hospital. I haven't got any of those questions since about, well, 3 years ago because they've got such great leaders, and Brittany and Katie's teams are great leaders, and the staff at the basic levels of the organization feel that their managers have their back, and they have an empathetic and sympathetic at times manager to voice their concerns with. So I don't have to say to them, no, you should go speak with your manager. I don't get that anymore. And the third and last point before I pass that along is, and Brittany alluded to this as well as Katie, our staff well-being.
Mhm.
We're investing in them, and that's a cost.
Yeah.
And before your time, one of the board members asked me when I presented a large expenditure amount to them, and this was about investing in staff, whether it's leadership or well-being, mainly on the leadership development side. The question asked of me was simply stated this way: Frank, it's a lot of money. What if we invest all this money in our people and they leave? I said, well, that's a great question. And let me answer that with another question. What if we don't invest a nickel in our staff and they stay? What type of a culture and environment are you going to be proud of?
Yeah.
And they said, touche, go ahead and invest in that.
Well done.
But maybe I'll pass it off to my colleagues for some more color. But those are three things among many that are touch points for me to see the organization heading in the right direction.
Thanks, Frank.
So, who's
Katie's
next?
Katie's giving me the nod. She knows I'm chomping at the bit.
No.
No. Can you tell that we're all really passionate about these
Yeah.
things? Um, so you said, maybe it's hard to talk about because it's second nature. I think for me, it's only second nature so much that I invest a lot of time and effort in it. It's something I care very deeply about, but it is very deliberate. So it is not something that is just this, innate trait. I think empathy to some extent is an innate trait, but the behaviors are not. And it is something that you have to think about and practice. And Frank talked about transparency and communication. That's the first thing to go when you're under stress.
Yeah.
And I am guilty of it, just like everybody else is. We are all human beings and we all get stressed, and communication is so easy to let slide. And I'm going through an issue right now with one of the projects that I'm leading, where it's taken twice as long as it should have. The staff who are on it, there's only a few of them. They are the only people in the organization who have the expertise to do the project. They are very burnt out and very frustrated. And I have their best interest at heart. I want them to get through this project so they can get back to a work life balance that is reasonable for them. But one of the things, and I just spoke about this at senior leadership the other day, there's a psychology of burnout where when you are burnt out, you hold on to control in order to feel safe. And when people are very burnt out, and this team is, they want to maintain control so that more errors don't happen that they then have to fix, right? You hear people say that it'll just take more time for me to teach you how to do it than for me to do it myself. But the problem with that, and we see this as parents,
Yes.
is if you don't teach people how to do it, you're stuck doing it forever. So next month and the month after, what's going to be in your best interest? And I've had to have some really tough conversations that didn't feel the best at the time that hopefully a month from now will actually reinforce trust instead of the other way around. Um, but what's important when you are making those decisions that you know, like, hey, I am taking control away, and I know that feels really awful for you right now because you are in burnout, is explaining, right? And doing that work of saying, I understand why you're pushing back on me. I am going to pull rank here and I'm going to take it away because this is in your best interest and it's in the organization's best interest. But genuinely, as a human being, you need to have other people be able to help you, and you cannot continue this way. So I think, bringing it back to that ethical lens and trying to be fair to people and make workload really appropriate, you have to be very deliberate about that. The the other thing is apologizing. I'm very quick to apologize and own mistakes. I think that people can sometimes think that if you apologize for something, it makes you it highlights the thing you did wrong, and it means that people will focus on that mistake and that they're gonna, hold you to account. In my experience, more often than not, when you are willing to apologize, it actually reinforces trust because people know that the next time something goes wrong, you are going to bring it up and you are going to fix it. So it creates a process that people can rely on. There's a threshold.
Yeah.
If you're continually having to apologize for something, it means you're making too many mistakes.
Mhm.
So, there's
Keep
things
an eye on
that
that.
yes, you need to like actually have the baseline. There's a baseline level of competency that's required. But I think, if you are somebody who is competent, is passionate, is doing things in a genuinely thoughtful way, and you make a mistake, which happens, then apologizing is your best bet. And then the last thing I'll say is that people are people first and employees second. And when somebody is struggling, and we have so many examples of this on our team, everybody goes through hard stuff in their life, whether it's, a death in the family or a health crisis for themselves or just their car breaking down. Being a person first and foremost and asking that person how they are and what you can do to support them and being there and saying, here's what we can do at work to make sure that you are supported and are able to take the time away to do whatever you need to do in your personal life builds so much more loyalty than trying to push through and get that person to deliver when they're not their best self. Um, and that can be really hard in healthcare because not having enough staff on site can be a real crisis. But you are, in the long term, I think, so much better off taking that initial hit and really prioritizing the person first, and the work second, than trying to just get people to be efficient automatons. It's not going to happen.
No, that's very true, Brittany. If I can just add just another point of color, we often say, and organizations say this, not just ourselves, we're a family. We call ourselves Team KDH. We're very proud of that. But it's more than just a slogan on a t-shirt. Really, it's really an ethos. And you need to invest in that. No different than your own family, personal family. You want to have a good, open, transparent communication channels with your kids and your spouse. You also want to apologize, and you should apologize, right? If need be, it creates a safe space. That's all part of the safe space. So we try and build. I can speak for all of us. We try, and I think we're succeeding each and every day to build an organization that we're so proud to work in. I don't look at this as just a way station job before my next job. Quite frankly, I had opportunities to move on. I'm so invested in this place because it's invested in me. They reward my leadership. They feed my juices, and they're on my fuel for wanting to show up every day. And that's key, showing up every day. But I'm not showing up alone. Showing up with these two folks and many others. So that's what really drives me, working towards that culture. And it takes a long time. We talked about how long it takes to build trust. It takes a long time to make that cultural change. But I see that. And my final point on this, it's not just our realization of this. Katie mentioned, and so did Brittany, we had just recently had an accreditation survey. And we're very proud of what we do. It was played back to us in spades during the 4 days visiting with us. They sensed it. It's visceral almost, it was palpable. And I was so proud to hear that. I was proud of everything they told us, but when they talked about our culture and what they perceived, I thought, you know what? That's some validation, confirmation that we're doing the right thing.
Amazing.
Yeah.
And Brittany, thanks for that very candid kind of run through of, based on your lived experience. I think there are a lot of leaders who are driving transformation and change for whom those ideas will really resonate. Like a lot of them are in similar situations and trying to support their teams as well. So appreciate that.
Yeah. What they said.
Right?
I was like, okay.
Sorry, you have to go last on this one.
No, it's okay.
And
Well, I do think I come in with a bit of a unique experience because I joined KDH last year. And my very first day, there's something called the Open Forum, which is chaired by Frank, our CEO. And I thought this was made up for me. I was like, is this just because I joined? It's not. This open forum includes all staff, our patient and family advisors, board members, physicians, anybody can come to open forum. I could not get over as a new member of the organization, the transparency. And this is something that I really value. It's part of my value, and I've really struggled with as a leader. I really believe in being authentic. Brittany and I love being honest to a fault because it's so important and it's part of that culture. But coming to an organization where a CEO, starting from the very top, that filters down through, and when you go and you talk about the psychological safety part of that, where we know that we can talk transparently, and the managers can come to either one of us, Brittany or I, and it doesn't matter who they report to, but they can say, I messed up, or I think I messed up, or this might have happened. It happens regularly, and not because they make mistakes, but because they want to make sure that they do a great job, and they feel so comfortable to come to us at an early stage in the game. And oftentimes it's nothing. It's just they just need some reassurance, and that. But I think that leadership style starts from the top. And I often talk with my peers and just colleagues around my experience in Kemptville, because it's been a year, and so you have that honeymoon phase that you think might be over, and it's not. Every day I'm just excited. I'm more excited to work with this team. I really felt like coming to Kemptville allowed my wings to spread and for me to fly, and Brittany, and that comes from Frank's leadership, from the board of directors who really puts their trust in us, and they're really representative of the community that also does that same thing. We're a unicorn.
Amazing.
Yeah.
Well, that's why I wanted to have you on the show.
Well, it's so funny. Like it sounds, I feel like sometimes it sounds so fake the way we talk about each other.
It's real.
Because it is such a bizarre thing, but there is just such a deep level of admiration. And it's not just the three of us. Like I was saying this on my corporate management team meeting the other day, and we were just talking about, things that have motivated us recently. Like we were doing an icebreaker. What has motivated you recently? And it just, as it often does, turned into this like, iterative process of just how much we all love each other and love working here and how great it is. And we're so fortunate. And like, I can't get over that 4 years in. Like I am still feeling that way. And especially, I keep on saying like in healthcare, you have really bad days. There are really genuinely bad days in healthcare. And the people that you work with are so important to be able to trust them. Like the dilemmas that you face in healthcare, the ethical and moral distress that is possible to experience in healthcare is different. And you need to be able to lean on the people around you. And we have that. And I think that's something I would encourage every organization in healthcare to do, whether you're small or big, is to really get a strong understanding of whether that exists at your organization. And it can be department by department different. There are still departments at KDH that need more support because they have maybe more casual staff or because they went through a really hard time recently and it's taken a hit, right? And so reinvesting in that culture in targeted ways so that everybody is feeling that love and admiration for each other and feels like they have teammates that they can rely on and lean on when they are having that bad day keeps people in the organization and keeps patients safe too. Because, when we're talking about willingness to admit to mistakes, it's not just the managers, it's the managers then passing that on to the frontline staff to be able to say, "Hey, I think I did this wrong," in a patient encounter. That can be, again, like a life or death situation, and if somebody tries to cover that up instead of speaking up, and this gets satirized on TV shows all the time. Like, it can often be a plot point in Grey's Anatomy or something like that. And having a culture of transparency and an ability to admit when a mistake has been made is a genuine patient safety initiative that needs to be invested in every healthcare organization.
Absolutely.
It's so
Yeah.
counterintuitive. We get excited when people are reporting more and
Right,
when we
yeah.
are seeing more of these reports come in. And because inevitably we're also seeing those additional compliments, but we're seeing an opportunity to improve,
Yeah.
but also
Yeah.
just the recognition that people feel comfortable. And I do want to highlight this again that it really needs to come from the senior level. It needs to come from the team.
Yeah.
I've been in organizations where the managers, the frontline staff, they care so much. And it's not to say the senior leaders don't care, but they're so far removed from
Mhm.
what's happening at the front level. And so having a senior team that walks around is great, but also really taking that time to understand and not just my portfolio, but I want to understand what Brittany's team is experiencing and how we can support that team because I rely on Brittany's team to provide support for my clinical team.
Mhm.
Absolutely.
Yeah,
Absolutely.
and if I could just make just two additional comments, I'd be remiss if I didn't make them. Um, what motivates me is not only doing the right thing as a leader, but I'm required to do this as a CEO by the board. I mean, we've got a great board chair just started this past June, Aaron. We meet almost probably every 2 weeks, and she wants to learn more about how the organization is progressing, and she expects us all to behave in this way.
Mhm.
And my second and last point I want to make would be, again, I'd be remiss if I didn't give a huge shout out to all of the staff, physicians, and volunteers. We talk about leadership, but we're working with a fantastic team, Team KDH, and we've got not only a great board and great political leaders at all levels of government, so the local, the regional, provincial, and even federal, they're behind us. The actual staff, they are counting on us each and every day.
Mhm.
It's kind of, it's a lot of pressure, but in a good way. They're looking to us to lead, and we're doing it for them. And they sense that, and they're willing to put in a little extra. They go to the extra mile because they know this is a giant enterprise that we call Team KDH, and we're just getting started. I think the potential is limitless, and I can hardly wait to see what happens tomorrow, let alone 6 months. So,
I can feel it, and I'm sure that people who are listening can feel that too. And one last question, just looking forward at the future, we talked about at the beginning of the show how your area is growing, the population is
Mhm.
growing, lots of different people coming in.
Mhm.
Sometimes the care is becoming more complex, kind of thing. Is there anything that the community should be expecting more or less of, as you move forward, as you look at your next initiatives, as you look at growth, as you look at communicating with them, as you look at your new
Yeah,
strategy that you're building out?
great question.
Anything that the community?
It's a great question, and you know this, we know this, but your viewership and your listeners may not. We're getting ready for our next strategic planning cycle, starting in early next year, probably February, March. We'll start communicating that. One of the more exciting, or two really important sessions. One is staff engagement. Everybody's invited to participate. We want to hear what their aspirations, their dreams are, their notions of our next step. But I really, really like as well to hear from the community. We engage with our community. Like, what are we doing? What do you like? What are your suggestions? What are you hearing? Because there's a lot of intelligent people in and around all of our communities,
Mhm.
and we want to tap into that richness. That intel is, again, I use the word a lot, but I really mean it, inspiring. It really is our fuel. It makes us want to do better for them. So I believe, and we'll have lots of, and Brittany would be involved as well as Katie, lots of new ways of reaching using tools, digital tools, lots of new ways to communicate with their public to get that engagement being meaningful two-way engagement. So if anybody's listening from our catchment area that was fairly broad, from Prescott to Barhaven, from I guess just east of Merrickville, and then all the way into the western parts of Winchester. We have got a huge area that we're looking at reaching out to and engaging with. So look
Exciting.
forward to that.
Good timing for that.
I think it's really important to highlight, especially for our Ontario Health and Ministry folks that might be listening, the primary care work that's being done in the province is really top of mind right now, and it
Mhm.
goes back to the fact that we are not just a hospital, but we're really part of a health system. And I had mentioned earlier that I was part of developing an expression of interest for a new nurse practitioner-led clinic on campus at Kemptville Hospital. We have the space. We've also partnered with all three of the family health organizations. They're willing to look at merging electronic health records, how we can work together as a system, community paramedicine being embedded directly into that, collaborating with public health. So those public health services can be embedded into primary care. And then again, bridging those quality improvement metrics that transition from hospital to community seamlessly. And that really is so we continue to grow and support our growing community. But it's a demonstration that we're not just a hospital, but we really do want to be the blueprint for other communities. And so we are looking very forward to getting that funding announcement in January and all of the funding. We're looking at expanding to supporting 10,000 new primary care patients that currently do not have access to primary care. By supporting primary care, it also supports our hospital system. And as I mentioned earlier, especially with the pandemic, we've seen that system pressure just exponentially elevate. And
Mhm.
so, as a hospital, it's a privilege as a primary care nurse practitioner to be to be an executive as a hospital at a hospital and develop a primary care strategy in partnership with our community. It's a dream job for me, but also for the community to know that we are not just a hospital. We really are caring about what that future looks like from the entire health and social service system.
Yeah, I'm glad you highlighted that because I made that point in my first board meeting when I said to the board members when we had a lot more face-to-face meetings. Thank goodness we're getting back to them. I
Mhm.
said to the board members that night, when you leave the hospital tonight, you look up at that blue H, and I don't want you to think hospital. I want you to think health writ large in the broadest sense. And we try, all of us do this every day. We try and bring everybody along on this system journey that we don't want to be known as a hospital. We want to be known as a strong, supportive partner in a larger health system enterprise. That's what motivates us.
Mhm. Yeah.
Okay.
So one of the things that I've taken to saying, it's become a saying of mine, is that we are a small hospital, not a small organization. And I think that's really important for people to understand in the context of healthcare all over the world. When a hospital says, oh, well, we're a small hospital, that that doesn't mean they are a small business. They're not a mom and pop shop. We still employ about 300 people plus our physicians. So that's not even including physicians. We are a major employer in the region. We're also a major draw for people into the area who are looking to buy a home. Like that's often something, people check school districts, they also check time to an ED, right? So being able to plan for the demographics of the region and making sure that we have enough services for that region is so important on so many different levels. But when you're asking what are people going to be, looking for from KDH, um, we've just implemented a CT scanner this year, and that has enabled so many more services to be available at our hospital. It's also going to drive volumes to our hospital, which is counterintuitively not helpful for the budget in a publicly funded healthcare model. And it becomes one of those things that I think our partners at the center, whether it's Ontario Health, Ministry of Health, needs to really understand is those misaligned incentives. So we're doing things that are, really value add from a patient perspective and from a community perspective, but are creating pressures for us from a financial perspective. And so there's a lot of planning that people don't know about behind the scenes at the senior level, at the board level, that is just trying to figure out, okay, what can we do? We know this is what we should do. We know this is what the community expects. And we didn't even bring up, but one of the things that is a huge driver in the system right now is the patient expectation. So patients now have an expectation of the level of care, the level of technology, the level of security, all of these things that now we have to follow suit. We have to deliver on, and the level of education that patients have and that is available to them in their pocket in their cell phone to be able to double check us is is really holding us to account in a new way, which is great, but it costs money. And there is only so much in a publicly funded healthcare system. So finding creative ways, I think, is something as a senior team we're putting our heads together, and not just within our own walls, but also within the region to try to make sure that this whole Ottawa Valley is being serviced appropriately, has good access to care, and that the wait times are being kept under control.
There's a
All
lot
right.
to think about.
Yes. Yes.
I just want to say what a joy and an honor and a privilege it has been to have all of you at the table here with me to talk about a lot of these, issues and opportunities, but also, what you're doing, and to really, showcase how you work together and how all of that comes together to really serve the community and to serve patients and how that's going to look in the future. So thank you very much for
No,
your
thank
time
you for
today.
having us.
Thank
We're
you.
Thank
admirers
you.
of your podcast and now we're a guest. So-
Well, we're expecting to come back because we still have so much to say.
I think you do. I think you do. I know that you do. And I'm excited about that.
We've
And
got
so,
3 more pages.
yeah. Thank you so much.
Thank you.
Thank you.
And for all our listeners out there, I hope you've enjoyed this show. It's been very special, for me. And if you like conversations about change and if you're driving change, I'd encourage you to subscribe to Wired for Change and come back again and see us next time. Thanks so much.